I'd like to welcome all of you to this Southeast Asia region of DFood International Awareness Week. And we have the president of DFood International, Dr. Zulfikar Abbas from Tanzania. We have the chair-elect of the Southeast Asia region, IDF, with us, Dr. Banshi Sabu. We have the regional advisor for Southeast Asia region, DFood International, Dr. Milind Roke. And Dr. Badud will be joining in about a minute. I just talked to him. And I'm the immediate past president of DFood International, Dr. Vijay Vishwanathan. So we are going to first have a 2-minute video on this Diabetic Foot Awareness Week from the president. Ali, can you play it first? And then we will go ahead.
It is an honor and privilege to address you today as President of DFood International. I speak not only to the diverse and vibrant individual present here today, but also to hearts and minds of millions worldwide, united by a common cause to combat diabetes-related food complications. DFood International is an organization consists of people working in the field of diabetes-related food complications. These people are spread across 7 regions in the world: Sub-Saharan Africa, South and Central America, Middle East and North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific, all dedicated to providing preventive food care for people with diabetes through awareness, education, and professional guidance. The looming global diabetes epidemic is a step reality, projected to rise with the highest burden in low middle income countries. As diabetes rates surge, so does the incidence of diabetes related complications, including food related complications, which is our focus of action here at DFood International. Our mission of DFood International is resolved and clear: ending avoidable low-limb amputation due to diabetes worldwide. It is not just a vision, but a mandate, a call to action demanding our utmost attention and urgency. We should all unify our goal and aim for a 50% reduction in limb amputation rates by 2026. In this mighty ambition, education and the empowerment of healthcare profession are our only weapons of choice. As I often say and will continue to say, education is only powerful tool we have. Education is power, especially in the low middle income countries, where it is free and immensely effective when properly implemented. It is noble pursuit. We at DFood International are proud to see the happenings of Diabetic Awareness Week campaign. This campaign, we find each one of you as a faithful ally in this great endeavor. The success of DFood International goals depends on your patience and efforts for educating communities and obviously raising awareness. Diabetes Awareness Week campaign is one of the flagship program of DFood International. As every year, this year we'll have programs in all the regions starting from 7 to 14 November. We have one day allocated for global meet where all the regions come together on one platform. Today, I invite every one of you to picture a world where every healthcare professional is prepared to offer knowledge and skills to provide specialized food care. Imagine a nation where stigma attached to preventable amputation is eliminated and a gap between affordable and accessible diabetes food treatment is permanently addressed. Coming closer to the end of my short introduction, DFood International extends a hand of collaboration to every one of you. Let us work together to promote care of diabetes-related food complications and their management, making it financially feasible and increase awareness about it. Lastly, I would like to personally thank everyone present here today for being part of this noble cause. We look forward to the impact we can create together. Thank you so much. Thank you.
Thank you, Dr. Zulfikar Abbas. First of all, he's in UK and he's taking part in today's meeting. And we have the first talk by Dr. Banshi Sabu, As I told you, he's the chair-elect of IDF, Southeast Asia region. And I would like to introduce Dr. Wadud, who's a brilliant surgeon from Dhaka, Bangladesh. I had the opportunity to see the fantastic work he's doing. And we will have a small panel discussion after Dr. Banshi Sabu's talk. So, Dr. Abbas, I know you are in a meeting in UK. So, you can listen or I leave it to you.
Thank
So,
you.
the diabetes, it's a World Diabetes Day tomorrow. It's World Diabetes Day fixed by the IDF, and we have none other than the chair of the SCA region in IDF, Dr. Banshi Sabu, chair-elect Dr. Banshi Sabu, who will be talking about diabetes in the Southeast Asia region. So on to Dr. Banshi Sabu.
First of all, thanks, Dr. Vijay, for giving me this opportunity on eve of World Diabetes Day and doing this great activity to increase awareness in Southeast Asia region. First of all, I congratulate you, D-Food International, and particularly our president of D-Food International, Dr. Abbas. I'm thankful to Dr. Vijay Vishwanathan, who is immediate past president of D-Food International, and the other panelists and organizing committee of D-Food International to keep a online webinar on World Diabetes Day, on the eve of World Diabetes Day, and to create or increase awareness about diabetic foot issue. I am given an opportunity to talk on diabetes in Southeast Asia region. So let me share my screen and give me just 30 seconds to. Is it visible?
Yeah.
Is it?
Yes.
Yes. Yes. So to start with, I have been given 15 minutes and I'm sure I will finish in next 15 minutes. As I am currently chair-elect of Southeast Asia region and International Diabetic Federation in different region, it has been divided and I am been elected last year as a chair-elect of Southeast Asia region. I don't have any financial disclosure to make for this particular presentation. As we all know that diabetes is really becoming out of control. At present, 537 million adults are living with diabetes. And I'm sure many of you who are listening here, every time the IDF Diabetes Atlas come, every 2 years before the World Diabetes Day, they release the Atlas. And this year also in 2023, they are going to release maybe in first week of December, because when the International Diabetic Federation meeting they are going to have on diabetes and complication, we will get the new number. But whatever the number which is expected in a diabetes, we actually get that number before 5 or 10 years. It's a global epidemic, out of control. Diabetes pandemic is a global threat. They had no socio-economic or a national boundary. So all over the world, whether they are lower economic countries or they are high economical countries, they are from different regions, but actually it is increasing like anything. In 2021, the 10th edition of IDF Atlas estimate 1 in 10 people adult aged between 20 to 79 have diabetes. It means almost 1/10 of adult population all over the world is having diabetes. It means this equates to 537 million people in the world. And by 2045, this number will increase to 784 million. But again, as I'm telling you, whatever number which is being released by IDF or by World Health Organization, again, this is the prediction. Maybe in 2045, we are predicting number is going to become 784. But in real life, actually this number we get before 5 or even 7 or 8 years. So I mean, this 784 million, we may achieve maybe by 2035, 37 or 38 only. There still remain gaps in our estimates due to absent and a low quality data in some parts of the world. So I mean, this is also one of the reasons maybe we are getting more and more data from all over the world, and we will get that, yes, this number is maybe in 2040 or maybe 35, we have 784. There is a strong need for an effective intervention strategy and policy to stall the increase in the number of people with diabetes in developing world or diabetes which is happening all over the world. So there has to be some intervention. There has to be some diabetes prevention program all over the world. That's the only way we can control this global epidemic. It's a complex interplay of a socio-economic, demographic, genetic, and environmental factors. And they've all been attributed to the worldwide surge of diabetes. So it's not just one reason why people from this particular economy or social or demographically, why they are developing more. There are many more genetic and epigenetic factors which are responsible for this. As this has been highlighted very clearly that 1 in 10 is diabetic, 1 in adult has impaired fasting glucose. I mean, almost similar number or maybe half of that number have impaired glucose tolerance also. Now, this is very important. The 3 out of 4 people with diabetes, they live in low and middle income countries. And this is important from Southeast Asia point of view. The Bangladesh, India, even the Pakistan is not as a part of the region, but that is politically, but it's actually Southeast Asia. This Indian subcontinent, which is a low and middle income countries, we have, if you see out of whatever the number which has been talked, we have 3/4 of them are living in low economical countries. The more problem is half of the population, they don't know they are diagnosed with diabetes. So this is also very, very important. 1 in 6 affected by hyperglycemia in pregnancy, and 80% of mothers have GDM. 11.5% of global health expenditure is spent on diabetes. 1 in 9 adults has impaired glucose tolerance. 1.2 million children and adolescents below 20 have type 1 diabetes. Now, this is again a very important number. I will be talking more about the Southeast Asia, how many children we have diabetes in our country, and 6.7 million deaths attributed to the diabetes all over the world. Now, this is how the regions are divided, but we are more interested for Southeast Asia, and it is increasing by 68%. Then someone say that, yes, in Africa or in MENA region, is it increasing more? Actually, they are getting more and more newer and newer data from different countries, and that may be the reason that they show slightly more increase, but Southeast Asia, the increase is really very, very high. Now, as I told you already, 4 out of 5 people with diabetes live in low and middle income countries. But what is more interesting, if you see the lower and middle income countries also, the peak is not just 55 to 59. They are getting diabetes even in their younger age group also. So in 40s, people are getting diabetes, and that's really a challenge for the countries which is already low and middle income countries, and they are getting diabetes in younger population, and particularly from Southeast Asia or from Indian subcontinent to the Western population, we are getting actually diabetes almost 1 decade or 1.5 decade before. And that's really a very challenging issue for India, because if someone develops diabetes in this 40 and they develop complication by the 55 or 60, that's more debilitating and more effect on the economy, rather than someone develops diabetes at the age of 55 or 60 and they develop complication at the age of 70 or 75. So that's the reason that we have economical burden of these problems is more, and morbidity living with diabetes complications are more in our country. The number of adults in our country is more than 100 million. I will show you the recent data which is published by V. Mohan and group. But if you see the China, the other country, the USA, is also having more than 20 million people with diabetes. But India, Pakistan, Bangladesh, China, and some other countries who have, and even the Indonesia have higher number of people with diabetes. This is the recent data which is published from V. Mohan and group. It is an ICMR in-diabetes study all over the world, all over the country. This had shown that in India, at present, we have 101 million people with diabetes. Now, what is more important than this, that along with 101 million people of diabetes, we have 136 million people with pre-diabetes also. Now, what is more important is that we have dysglycemia, which is 236. It means those who are at the risk of developing diabetes, and okay, even their HbA1c may be less than 6.5 or even 5 below 6, but still they have dysglycemia. But what is more important than other than these diabetes condition, the other non-communicable disease in our country like hypertension, the generalized obesity, the abdominal obesity, the dyslipidemia, and high LDL cholesterol, those risk factors are also very, very high. It means the people with diabetes, along with other risk factors, which also have a common soil for pathogenesis, they are going to develop a lot of cardiovascular complication because of their other cardiovascular risk factor like hypertension, dyslipidemia, central obesity. These are the problems which are also very, very high in our country. And this is the data from India, but similar type of issues are there in other Southeast Asian countries also. As I talked to you about the rule of halves, which is exactly in our Southeast Asian countries, that 50% of people, they don't know, they are diagnosed with diabetes. The problem is another 50% of them are not actually receiving care. It means those who are diagnosed, out of them, only 50% of them are actually getting the care for diabetic patients. I mean, they care for diabetes treatment, and another 50%, it means only 12.5%, they achieve treatment target. So out of 100 people, we are going to have only 12.5 people. And this is target of, I am talking of glycemia. If you talk of all desired outcome, if you want their lipids to be controlled, their blood pressure to be controlled, their central obesity part to be controlled, their smoking cessation is to be done, maybe another half, it means only 6.25, they achieve desired outcome. And in some of the countries, even this desired outcome may be even less. So out of 100, only 5 or less than that percentage of the population actually achieving a desired outcome for these people. This has already been repeated. The prevalence of diabetes, which is increasing, and in higher income countries, it is increasing, but even low income countries and middle income countries also. This is where the India comes the riddle, which is also showing that increase in our early from 30, 35, this incidence is increasing, and even this is up to the 60 or 64 in compared to the higher income countries. While in the higher income countries, it starts from 45 and the highest is above the age of 65 or 69. So they get more age-related diabetes, while we get more of obesity, insulin resistant and insulin deficient varieties of diabetes, even in 35 to 40s. Hyperglycemia in pregnancy, again, a major challenge in our country. So women with history of GDM, they face an increased risk of developing diabetes later in life. GDM babies have lifetime higher risk of obesity and type 2 diabetes. Thus, the intergenerational cycle of obesity and diabetes, which is going on. So hyperglycemia in pregnancy is a major challenge for Southeast Asia. And this is the data of IDF 2021, which is talking that about hyperglycemia in pregnancy, probably in Southeast Asia, we have highest in compared to the Western Pacific or African population, or even from MENA region, in compared to Europe, North America, and South American region, it is much, much higher. So the number of people in millions, they are having higher in compared to the other regions as far as hyperglycemia in pregnancy. So the two important things which I talked about, one is the IGT, other is unawareness about the diabetes, and the third is hyperglycemia in pregnancy. These are the three major challenges in Southeast Asia, and probably we are much higher in compared to the other regions. And maybe in another 15, 20 years, we will be having more people with diabetes, which are in younger age. They will develop more complication if it is not been stopped. The impaired hyperglycemia or impaired glucose tolerance, which we call it IGT, it is often goes undiagnosed. Hardly we see the people who are diagnosed with impaired glucose tolerance. It is important because it indicates the risk of type 2 diabetes. But what is more important, it also indicates an increased risk of cardiovascular disease. It increases the risk of person with IGT are also at the higher risk of developing CVD. It gives a window period for a lifestyle and other intervention that can lead to diabetes prevention. So if you can diagnose someone, if you can know that someone is at IGT status, you can prevent them to develop full-fledged diabetes. So this is the time when you can really prevent the person with IGT. The number of adults with IGT, whatever the data which we have, at present, it is showing that Western Pacific population may have higher IGT in compared to Southeast Asia, but we don't know as the exact number of people with IGT in India had shown in recently published paper in 2021 of V. Mohan Group had shown 136 million, which is more than 101 million people with diabetes. So probably in Southeast Asia region also, it is more, and number of people with diabetes and pre-diabetes are also very high in our country too. Diabetes-related health expenditure as a percentage of gross domestic product, and this is again very important, is in India and in Southeast Asia, in compared to the North America and South America, even in compared to the European countries, our expense is really very low. So in compared to the GDP, yes, definitely our GDP is also low in compared to, but now it is the fastest growing economy. And we are now, India is almost like top 5 fastest growing economy in the world, but still the expenses, particularly diabetes related health expenditure in our country is very, very less. So the number of deaths which is related to diabetes are very high in compared to the infection disease. Still, we worry of more of malaria, dengue, and many more other conditions like tuberculosis, HIV, and AIDS. But if you see the how many million people who are dying because of diabetes in compared to the infectious disease, even if you compare with the COVID, we know that how many people have died because of COVID or other infection problem, you will find that diabetes-related deaths are much more higher in compared to any other infectious disease. In the top 10 countries with the health expenditure, if you see the India in compared to even China, because we are the second highest number of diabetic patients in the world, still our expenditure is negligible even in compared to the China, which is in the Asia only, which is our neighboring country, but still the health expenditure in Southeast Asian countries is much low. Even Bangladesh, I can show here also, even in Pakistan, Bangladesh, the Southeast Asian countries is much, much less in compared to the number of people with diabetes and our health expenditure. The total percentage of total health spending allocated to diabetes per region is also very low in Southeast Asian countries in compared to the SACA or North American countries. This is again very important slide from India only. This is published in 2021, that out of those people who are having diabetes, only 50% of them are taking glucose lowering medication. As I already told you that 50% of them are not knowing about the diabetes, and those 50% of them, again, those who are knowing diabetes only, they are taking care of their diabetes treatment. So they get the medication. Now, antihypertensive medicine is given only in 45%. What is very important, cardiovascular risk factor is lipids, and only 10% or less than 10% of the people are actually achieving the cholesterol. They are getting cholesterol lowering medication. The diet counseling, the exercise counseling, and weight counseling is roughly 1/3 of the patients for that. And this is very, very important. So it means we need to work on all these aspects. We have to improve first that all those people who are with diabetes, they should be given the glucose lowering medication, and our ABC approach, which is like A1C control, the blood pressure control, and cholesterol getting at a target level. These are the 3 very, very important. And then D and E, which is diet counseling and exercise counseling, should be included as a part of treatment. And if we can achieve for all these 5, for all those 100% of the persons with diabetes, at least we can prevent the complication. So we may not prevent the primarily the diabetes, or primordial prevention of diabetes may not be possible, but at this point of time, we can increase the awareness to decrease the complication or to prevent the complication in person with diabetes. This is the recent data of India, which is talking about our 2/3 of the population actually are not achieving diabetes good control. We are having 22.5% of the person with achieving type diabetes control less than 7, but 2/3 of them are not achieving, and more than 30% of the, or 30% of the population is having actually very uncontrolled diabetes also. For type 1 diabetes, again, one slide which I just want to tell you that we are the second one as far as type 2 diabetes is concerned in the world. But India having highest number of people with type 1 diabetes. And this is those who are listening, I think they all must know that we have 229,000 children below the age of 20 years are having number of persons with type 1 diabetes. And country-wise, we are the highest one. The second one is USA and Brazil. What is more important is we are not the top 10 countries as far as incidence is concerned. So we are not in the top 10 countries. The Finland is having 52.2 per 100,000 children having diabetes, while India is not coming in those. So because of large country and a big number of, people, we have very high incidence of type 1 diabetes, very high people with type 1 diabetes, even the incidence is low. And what is more important other than this, that every year 24,000 children are added in this list. This is to 29,000 children. And Southeast Asia, the poorer outcome for these type 1 children, they don't live their normal life and they develop complication within 15 to 20 years of their diagnosis of type 1 diabetes. We know that diabetes leads to multiple complications, but as here it is on a D-Foot International, I would like to talk about every 30 seconds, a lower limb or a part of lower limb is lost due to amputation somewhere in the world is a consequence of diabetes. We don't have the exact data from Southeast Asia, but as I told you, as we are developing diabetes in a younger population and so many persons with diabetes, and because of their poor care, we also develop a lot of people with diabetes, foot complication, and I'm sure a lot of diabetes amputation are also there in our country too. One thing which we can do, and this is what, and last, before 1 month, we started screening our people for a Indian diabetes risk score, which has been published long back in JAPI by Dr. V. Mohan and group, which is talking very simple thing about that. Those who have higher risk of more than 60, at least they should be screened for sugar level. So in this World Diabetes Day, as the theme is more and more screening, make people more aware about diabetes, and we are also celebrating the 100 years birth anniversary of Professor Vishwanathan across the country. On in this World Diabetes Day, we have created an app also, and we are screening across the country the people with higher risk for developing diabetes. We are screening them, educating them that how we can prevent them to develop diabetes. Also, we know that challenges are undiagnosed, and the solution is to diagnose them early. That's what we can do. We have to diagnose the people who are with pre-diabetes and IGT, and then to doing some intervention for prevention of diabetes. We should know about the hyperglycemia in pregnancy, educating the people for that. Diabetes in an elderly population, again, a big challenge, and a diabetes with complication, particularly complication like retinopathy and the foot complication, heart disease, renal failure, all these complications, how we can prevent that, we have to talk. And this is one paper which we have, before 2 years, we published that each and everyone who is coming to the doctor's clinic, maybe a primary care center or maybe at a tertiary care center, we suggest that actually sugar monitoring should be considered as a vital sign. The way the pulse, the blood pressure, the oxygen saturation or respiratory rate, or the blood pressure which is measured or temperature is measured, these are 4 vital signs which we normally measure. Any doctor, maybe a surgeon, maybe a gynecologist, maybe this, the simultaneously they should not miss the opportunity of measuring the sugar also. So it should be considered as a vital sign, and this is a new vital sign which also indicative of prognosis during hospitalization. So anyone who is getting admitted in a hospital or going for a outdoor patient consultation should be screened for sugar also. To summarize my talk, we have more than 537 million people with diabetes, and 64% of them, they live in Asia. 30 million people were more diagnosed in diabetes in the last 2 years. So, I mean, this is just in last 2 years, and half of people, they are undiagnosed. No disease has impacted human life stronger than diabetes. Costs are greater than any other disease. Diabetes is currently unstoppable and has impacted human life stronger, more problematic in rural area, as well as in low-income countries and middle-income countries. Complications are increasing in younger age, and we are seeing a lot of patients with CKD, diabetic foot, and retinopathy, which is increasing, and it is on rise. With this, I thank you. Thank you from India, and greetings from India. Thank you, everyone who are listening. And once again, thank you to D-Foot International, and particularly to my friend, Dr. Vijay Vishwanathan, for giving me this opportunity. Thank you. Thank you very much.
Thank you, Dr. Banshi. I think it's very important that we get an introduction to diabetes, and you have given us a very grim picture of the Southeast Asia region diabetes scenario. And I think it's very important that we try to prevent at least amputations, which is a preventable complication. Retinopathy, nephropathy sometimes is not preventable, but diabetes related palpitations are certainly preventable. Any questions, Abbas, from the chat box? No.
No, there are no questions.
Okay. So thank you, Dr. Banshi, for sparing a valuable time.
Thank
And
you.
We will have a
Thank you,
small
Dr. Banshi.
panel
Thank you very
discussion
much.
before we conclude.
And festival season is going on, so I will have to leave and some guests are there. Thank you.
So
Thank
happy Diwali and a very nice lecture.
Thank you. Thank you, Milan bhai. Thank you.
Very informative.
Thank you. See you in Mumbai. So,
Thank you.
Yes. Thank you.
Vijay, I have to leave as well.
Oh, yes. Thank you. Bye.
Thank you. Bye.
So we have a panel discussion with Milind Roke and Vadud, both are surgeons doing very good work in Mumbai and Dhaka. And since it's the Southeast Asia region, I think we need to know what's happening in India and in Bangladesh. So I'll start off one or two questions, and then I'll ask Dr. Milind to show some of his social activities which he's doing in Mumbai. So, Badud, you ready? Are you there? So, yeah. So the first question I'll ask my Indian colleague, Dr. Milind Roke, who's a surgeon. We have a lot of priorities. We have priorities like heart failure, retinopathy, nephropathy. What is your priority in your country, in India, in preventing lower limb amputation? What do you think is a priority? What is lacking? And what is the priority?
Sir, apart from the tertiary centers that we have in metro cities, there are a lot of lacunae I have observed because I am also working in medical colleges and a secondary healthcare center. The most important thing that I've noticed is this lack of orthotist. Even in a city like Mumbai, the orthotist who makes the shoe, and people are trying to get it made by any cobbler. It's not wrong to make a shoe from a cobbler, but he has to be trained, or he has to be supervised by the diabetic foot person. So orthotist training is lacking in India, and we don't have orthotist. The second most important thing is, even in some tertiary centers, there is no cath lab. So the lower limb vascularization is done mostly by interventional radiologists. So with due respect to them, they are doing interventional radiology for different organs. And for foot, you require a special experience, like in Jain Vascular Center or some very high volume centers where Dr. Pinjala from Hyderabad does in India. So that kind of centers are not there, where they can do a hybrid procedure or very low arteries, small arteries like posterior tibial to be dilated, or then the decreased cost of medicines, insulin cost, the cost of the stents and the footwear material cost. So these are some things that my country requires on priority, and that is why what Dr. Banshi Sabu said about the GDP spent on health, and this is where the government policies are important, how they could help the lower and middle income patients, because by the time they are not aware, so by the time they reach the proper center where diabetic foot care is there, they are almost done with the finances they have. The footwear is not covered in the Mediclaim, in most of the Mediclaims. So these are some of the factors which I think. The other factor is in medical colleges, the awareness in the students, undergraduate and postgraduate, has to be expanded, and it has to come in the curriculum, the treatment of diabetic foot, the preventive management, as well as the surgical management. I was in JJ Hospital and I taught people there, and I am now teaching in a secondary care hospital. Large organizations like many other organizations in diabetes in India, they should take up this. They should start a fellowship or a certification program which is authentic and recognized by universities, traveling fellowship, increasing awareness in people, patients, healthcare workers, and stressing the fact that what glasses are for eyes, footwears are for your feet, is going to be a very important thing that uh, a tagline which can always be stressed upon in different meetings that we have. So these are some things I think are needed in priority in India.
Yeah, thank you, Dr. Milind. I think I thought you'll tell about podiatry itself, preventive podiatry. So I would
Preventive.
like Sudh to talk about not only footwear, but the specialists for podiatry is missing in India. There are in the United States you have training programs for DPM, where in India or Bangladesh and Pakistan we do not have even podiatry training except in one center or two centers in the whole country. So I think that's a priority. So Vadud, yeah, I know you've been doing wonderful work as a surgeon in Dhaka. So what would you think is a priority in your country?
Thank you, Deefoot International, and our president, first and immediate past president, Dr. Bijoy, and all the participants. Thank you. Very good evening. Bijoy, all our scenario is almost the same as India, but we are a little bit behind from India in this regard. In our country, I think the difficulties which one we face, and that is the lack of diabetic foot care education among the diabetic population and the primary healthcare providers. That is the main problem, because we all know who are dealing with the diabetic foot that it is started with a small thing, maybe a small infection or ulceration in the toes and somewhere in the foot, and due to lack of proper treatment, it ends up with amputation. And so therefore I think therefore if we can set up, as Milind said, that the train the primary healthcare, educate primary healthcare, and make some podiatry courses and courses for the nurses who will take care of the diabetic foot patients. And in every medical college, we have to place the post for endocrinologists and train the junior doctors how to take care of the diabetic foot. And this is the very important. We have the lack of the manpower and with the lack of education. And the other thing, in India, what I saw, that you have some facilities to make the footwear for the patients, especially in your center, Vijay, I saw. But in Bangladesh, still we couldn't do anything for the patient with the footwear, proper footwear. And some of our companies that they're trying to make some shoes, offloading shoes, but they cannot make it. Because the patients, they are not aware about the footwear, and but they don't make it properly. Therefore, actual offloading is not happening. Therefore, we treat with the ulcer, and after 2-3 months, they come again with the same ulcer. Therefore, the footwear is the very important thing. And the other hand, I don't know, do you, what do you think about this? In our country, before COVID-19, we had peripheral vascular disease patients only around 35%. But now we are facing that almost 90% patients are coming with the peripheral vascular disease. And it is really, I don't know how to deal with this, because we have lack of the vascular surgeons, and especially the surgeons, they are not interested to deal with the peripheral vascular diseases. And the diagnostic tools, that is also the costly, and it is only in the large cities available, and we are facing this problem. And therefore, we need to start with the podiatric courses in the medical colleges and make some podiatrists. We'll take care about primary, give the primary food care. I think so. Mainly, this is the problem we are facing, Vijay.
So that's why the DFoot International has started a program called the Train the Foot Trainer program. So where it's an extension of the step-by-step towards preventing amputation. So the DFoot is now doing it in Saka. We did it in Chennai. We did it in Malaysia last 2 months ago. So we have the Train the Foot Trainer program where we are training the trainers. So DFoot International is trying to educate people. So we have reduced the membership fee according to the country from where you're coming, according to the World Bank. So we would encourage people to join DFoot International, because that's the only way to learn. The second question to my colleague from India is explain, Dr. Milind Ruke, explain the methods you adopt to, we'll finish another 15 minutes. Explain the methods you adopt to reduce the burden of DFU in your country. What are methods?
So in your private practice, the methods that we use, we all learn and we know, but especially in lower income group, especially in BMC run hospitals or corporation runs hospitals where poor patients come, we try to take different lectures, awareness and workshops in the medical colleges and the secondary care hospitals. We try to teach surgical techniques to so they can independently do the surgeries in the OR, and there are certain advanced wound products that we require sometimes to treat complicated surgical patients like Matriderm or some kind of skin substitutes. So we are getting it now sanctioned through local purchases, requesting the central purchase department to get those things. Then arranging social awareness camps in different organizations which are doing, whether it is IMA or it is Surgical Society of India or many other diabetic organizations. So we try to organizing committee to have a particular section on diabetic foot, good people to talk on and show videos of surgical videos, as well as having a workshop. Now we are having next month we are having a workshop in Nayan Hospital where we are going to train some people. But this has to be done free of cost also sometimes. Then we have started diabetic OPDs now in government colleges, which were not there in Mumbai at least. Hyperbaric oxygen centers are coming up in different locations. So these are some of the efforts we are doing, and more we are going to the rural areas and trying to start diabetic OPDs, which were never known. So last time when I went to Ratnagiri, there were a lot of General Practitioners Association, and they were not aware about diabetic foot dressings even. So training of family physicians who are the first reference for the patients. So these are the certain things at local level as well as in the state.
So I'd like to also announce that Christian Van Acker, the founder of DFoot International, who's taking part, has donated, and they, along with her colleagues, 12,000 euro, and it's slowly increasing the amount for implementing the IWGDF guideline world over. So we'll be announcing it very shortly, and we request all of you to utilize these funds, apply for this grant, and we will be able to implement the IWGDF guideline. So Dr. Wadud, can you explain the methods same question, to adopt to reduce the burden of DFU in your country?
Yeah. we know if we properly manage the diabetes, then the diabetic complication will be reduced. Therefore, the early detection and with the proper treatment of diabetes is very important. In this regard, in our country, many interesting things are doing. Maybe you know, Vijay, that from Diabetic Association Bangladesh, we trained the Imam of mosque because our many people goes to the mosque in the morning for morning prayer. We teach them how to do the blood sugar test with the glucometer, and in the fasting they do the in the mosque and take a little charge, and it helps both the people and the imams and those things. And before the marriage, we also train the marriage register. If the room are there diabetes, they talk with them how they will take the children and those things. And now very soon with this month we have started the mobile diabetic clinic, and it with all facilities to detect the new early detection of diabetic patients, and also the follow up the patient. And there is all the modalities to take some investigation and interventional thing. And they will connect it with the specialist digitally to take the advices and these things. And this is regarding the proper management of diabetes and those things. And I think we have to start secondary and tertiary type of diabetic centers in cities with the full spectrum of specialists and available all the dressing materials and those things. And we are facing the problem actually with the patient with the vascular problem. It is really, we are facing a great problem. We are giving them empiric treatment with the heparin and those things. Can I ask a question, Milindo? Do you use the prostaglandin? And what is your experience and what is the result?
Sir, you would like to?
No, you
So-
can go ahead.
So some of the vascular surgeons and interventionalists, they have recommended use of prostaglandin, and you get it in a vial and you give the entire vial diluted in normal saline and very slowly in an ICU setup. So for patients who are according or it is not plastable, this was recommended by some vascular surgeons. Some results are good, but it is not universal. Like we do not get 100% results in all patients, but it is a kind of treatment which can be suggested in fit individuals who do not have finances or if the lesions are not plastable. So that is a small experience that we have in India.
The third question which we had, yeah, you go ahead.
I had 12 cases, but they recommend that if you are not with the upper blockage, only with the distal parts, then you can use this prostaglandin. And therefore, you have to do the angiogram, and this is a costly procedure. And no, I did with the 12 cases, and in 9 cases, we get a good result. I don't know what will be the further. We should do the more cases, and then we can make some comments. Yeah.
Yes, practically some cases we got benefits, but evidence is little. We require more evidence for that.
Dr.
there is
Milind,
more
there's a question from Dr. James in Kenya. You had talked about Castham Young in Kenya. I'm not sorry, Castham Young in Madrid when we met, when Christian Vanaka organized a meeting. So he says we don't have podiatrists and we need to Castham Young. So would you like to say something about that concept of Castham Young?
Yes, sir. So what I am doing is a little way, because I am not associated with big organizations except for DFood. But I think with Sir Vijay sir, we will be doing a lot of activities with RSSDI in different associations and medical colleges. What what we do is, like, if we have a surgical conference, we try to request the organ have a workshop on diabetic food, lectures on diabetic food, so that the medical colleges students, postgraduate students which come, they get attracted to this. But even with that attempt, I do not see the surgical candidates coming to those part of the conference for diabetic food, because they are more attracted to the lucrative or more clean surgery, like laparoscopic surgery and all. So this experience we have, but we are still doing. Suppose we have a diabetic conference, we are trying to ask them to keep a lecture on diabetic food, a workshop on diabetic food. We have Association of Surgeons of India, the Maharashtra Association of Surgeons of India. There we are keeping lectures. In CMEs that we have, where we have to accredit for points for the doctors, suppose we have complications of diabetes, we put diabetic food. So this is how we teach the patient, and we give points. These points are required for people to get, to complete their registration every 5 years. So once we have points for the accredited CME, people attend. So suppose we have surgical infections, then one of the topic would be diabetic foot infections. So this we try to keep different medical colleges. We're now trying to get across to all government medical colleges and have a quiz program on diabetic foot complications. So these are some of the things we try to catch people, doctors who are at MBBS level or just past MBBS in surgery, and tell them that do not use Usol or hydrogen peroxide, but use saline, because those other agents can harm the patient, young growing epithelium. So all these things, if you tell them at a very young age about offloading, about what to use, what not to use, just giving a footwear or prescribing a footwear is not going to be. We have to see that after wearing the footwear, the patient is walking in a particular, and I've only seen there is a space crunch somewhere, but we should do something. I've seen in Coimbatore Ganga Hospital where they train the patients how to walk, and how the footwear should be changed every 6 to 9 months, because if they wear the same footwear for 9 months, it gets worn out. So all these things we have to tell make the students interested and tell them how this is going to affect the incidence of diabetic foot, the longevity that the patient is having nowadays, making them more prone for microvascular complications. And it's also a branch where it can be taken up as a profession, and it is not bad. It also in your private practice. But as you should have a passion, and that to develop that passion in a student, it really requires us seniors to work hard and see to it that we put this into their curriculum and into their, because we have a lot of diabetic foot surgery, more than letters, but you have to have the liking and the passion to treat them.
Thank you, Dr. Milind. Dr. James wants you to send the procedure for prostaglandin infusion. He's given his email ID, James Kenya. And we also have a comment from, you're muted, yeah. We also have a comment from Christine Van Acker that in case you do not have revascularization procedures, nothing to worry. First, the best win is early detection of the foot. You have the touch test of Jerry Raymond. We have the pulse examination of the eyes and pulses, and early treatment, and daily exercises by ankle exercises, stretching the feet. And so there's nothing to worry if you do not have revascularization procedures. My last question, yeah, you go ahead.
Alger Allen's exercises, how many of you are using that for revascularization as a physiotherapy exercise, Berger-Allen's exercise. Is Madam talking? I think Christian must be talking about that also.
Yeah.
That exercise is known as Berger-Allen's exercise. We should have some evidence also by using this, how much revascularization can be possible in patients with non-plastable or non-affording vascular problems.
Yeah. Dr. Vadud, my last question to you before we conclude is something similar to the second question. With the meager amount of money which our patients in India, Bangladesh, Pakistan, and Sri Lanka have, how do you manage cases of diabetic foot ulcer in your country? Something similar to the second question.
Yeah, in our country, 90% diabetic foot patient actually is treated by the general surgeon, orthopedic surgeon, vascular surgeon, or surgeons other specialties. They actually do not know about the diabetic foot wounds actually. And therefore, we want to make a national guideline for this diabetic foot patient, and if we can spread this one and made a good referral system, and maybe in that cases this patient will not suffer, because we know these patients are their hospital stay is long, and it is both costly for the patient and for the hospital. Therefore, a national guideline should be made for this thing. And I have one question. Do you facing the same thing after COVID-19, the increasing of the peripheral vascular diseases?
Peripheral artery disease is more common now after COVID. Maybe we are looking out for more cases, but we've definitely seen a 10 to 20% increase in the peripheral artery disease after COVID. The reasons I don't know. Maybe it's the clots in the arteries. I don't know what's the reason, but we're definitely seen what you said is absolutely true. We used to see some 20% of peripheral artery disease. We're seeing now 40%, 10 to 20% rise. Yeah. So I'd like to thank Dr. Milind. Milind, would you like to talk about your special programs before we conclude?
Yes, sir. On 9th, can I share a screen a little bit, sir? So on 9th of this month, we did a program in a secondary care hospital run by government called Khan Bahadur Kurla Baba Hospital. And we had we did about 50 cases of HbA1c free of cost to the poor patients and employees of this hospital. We did a neuropathy camp, testing camp, and if you can see here, I mean, D-Foot International, as a regional advisor, I tried to do some awareness here. And there is a bone densitometry camp also going on, and we gave the medicines for neuropathy and to increase the vitamin D and calcium levels to these poor patients. We had a overview of diabetes by a physician, Dr. Rajan Sheletkar, and there were mixed crowd of patients as well as sisters and doctors. I spoke on diabetic foot in the vernacular language in Maharashtra, which is and about the nutrition and diet, how it affects and different kinds of things that we are doing, how the podiatry is evolving in India, and the patient should not be afraid to come to medical colleges and get themselves treated, and amputation prevention I spoke about. This is one of the patients that we showed people that this was by 2-3 other medical colleges has said that we should do a below-knee amputation, but we could save this foot. And we have given him a footwear. We donated footwear to them because they were not affording. And we also at the end of the lectures, we gave them a talk on eye and eye complications in diabetes. So this is how we celebrated on 9th. And it turned out that about more than 100 patients came for this camp and they benefited. And we are going to do it in after every 2 months to have an account about what's happening and how the improvement occurs. Thank you for the
Dr.
opportunity.
Yeah, thank you, Dr. Milan. You have been doing so much of social service and CSR activity every year around
Every-
this time, World Diabetes Day. So we'd like to thank Dr. Banshi Sabu, Dr. President Zulfikar Abbas, Dr. Wadud, and Dr. Milind Roke for taking part in this Southeast Asia region. And we thank our founder, Christine Van Acker, for donating 12,000 euro with our colleagues. And we will be announcing it very soon. This is available to implement the IWGDF. My only request to you is, I'm in wound healing and offloading group of the IWGDF guideline. The data from China and from Southeast Asia is lacking. So even if you're doing, if you are doing a lot of limb salvage, I think you should publish it, because when we see the PubMed and when we read articles, none of these articles come into reckoning. So we tend to take studies from Europe and from United States. So though we are doing a lot of good work, it doesn't get recognized. So my only request to Southeast Asia region is to publish in reputed journals so that it will come up when you search, and the IWGDF will be too happy to include those studies from the developing world. And from the developing world, we do a lot of limb salvage, so that should be documented. So I would request Dr. Wadud and Dr. Milind Roke to publish in journals which can be picked up by the IWGDF. So thank you very much. And I would like to thank Mr. Ali for giving us this Zoom link, and also DFoot for organizing this program in each region every year. Thank you so much.
Thank you. Thank you, everybody.